Welcome to today's podcast dealing with disclosure of patients' health information in mental health settings. And whilst this podcast is directly applicable to psychiatrists in New Zealand, there are principles which are applicable for all clinicians who treat patients with mental health illness. My name is Dr. Sam King and I'm a medico-legal consultant with Medical Protection, and I'm joined today by two other clinicians and one lawyer. Sorry, Joe. Is that an insult or is that a compliment? I'm not quite sure.
A huge compliment. I will take that any day of the week. Thank you, Sam.
So we do have Joe Fitzgerald. He's a lawyer with Watton & Carney, one of our panel law firm. And Joe has a specialty in dealing with privacy issues. We're really grateful, Joe, to have you join us today.
Thanks, Sam. It's a real pleasure to be here.
With me also is Dr. Mark Burns, who is our resident psychiatrist, or one of our resident psychiatrists, who works as a medico-legal consultant. And I'm also joined by Dr. Tim Cookson, who is another member of our team, a medico-legal consultant with MPS. Tim's background is general practice, as is mine. So thanks for joining us, Mark and Tim.
Pleasure, Sam.
Good morning.
Mental unwellness can at times be associated with an increased risk of harm. This may be the risk of suicide or sometimes a risk to someone else. Incidents of harm that involve mental health patients attracts high media attention. And although statistically one is less at risk of harm from a person with mental health difficulties than the young substance abuse male living next door, there are times when mental health clinicians need to take actions in order to avoid harm. And this may involve considering limited disclosure of health information. And today we are looking at thresholds for making such a disclosure without consent. Mark, maybe we start with you because you are the psychiatrist. Would you mind just sharing with us common scenarios where we might be contemplating making such a disclosure?
Yeah, thanks, Sam. Look, there's two common scenarios that we face in psychiatry. One involves the requirement to consult family under the Mental Health Act, and another is the disclosure of health information to reduce the likelihood of harm. So obviously the starting point is the privacy of health information, and in psychiatry it's often particularly sensitive information. So if we think first of all about the requirements under the Mental Health Act, this is a requirement to consult with family or whānau, and this is under Section 7A of the Mental Health Act. And this requires that the responsible clinician must consult with family or whānau during the compulsory assessment and treatment process, unless it's not in the best interests, that's the language of the Act, or if it's not reasonably practicable. So Section 7A places this responsibility directly on the responsible clinician. The key worker or the case manager can help facilitate this, but is the task of the responsible clinician. And that consultation is a two-way process. Information that's disclosed by the responsible clinician may be needed to help develop a treatment plan with the family or whānau who will be involved with that. So the responsible clinician must discuss with the patient to obtain their views about the proposed consultation with family. So the requirement to consult with family does not mean a patient gives up their right to confidential care and treatment. However, if the patient lacks capacity, clearly then consent is not required. But if they have capacity and do not wish for there to be consultation with the family, then there needs to be consideration of best interests, the term that the Act uses. So if family will be providing ongoing care of the patient and the patient refuses consent to the disclosure of health information, then this still can be disclosed under certain sections of the Health Information Privacy Code. Of course, the responsible clinician must use their discretion to decide how much or what information is disclosed to family so that they can make informed responses to the proposed planned treatment or the assessment process.
Thanks, Mark. Just a little question there. I'm assuming then, you're talking about the responsible clinician who are using the Mental Health Act.
Yep.
But if they require, or if they are relying on the Health Information Privacy Code to be able to release information safely. Therefore, all clinicians would be able to use the Health Information Privacy Code, or the HIPC. Would that be right?
Yep.
That's great. Joe, would you mind just telling us or our listeners a bit about the HIPC?
Yeah, of course. So the HIPC is a code under our Privacy Act. We got a new Privacy Act in 2020. Before that, we had the Privacy Act 1993. And we had a previous Health Information Privacy Code under that Act as well. What the Privacy Act does, it acts as the sort of the bedrock for managing personal information in New Zealand in all contexts. It applies to every agency that sort of collects personal information, stores it, uses it, discloses it. In specific areas, the Act makes provision for the creation of codes. So we have codes for things like telecommunications, credit monitoring, emergency services, and we have a code for health information. So what that code does, it provides a gloss, provides additional rules in specific areas for the use, disclosure, storage of health information by basically the healthcare sector, anyone who's dealing with healthcare information. And it augments the Privacy Act. So the Privacy Act is built on a series of principles, 13 principles. Our Health Information Privacy Code has 13 rules. These are sort of variations on those principles. There's various other areas that it tweaks as well, but much of it then refers back to the Privacy Act. So for the specifics of things like what you need to do when someone asks you for a copy of notes, you might start with the Health Information Privacy Code, but the detail will be found in the Privacy Act itself. So it's a gloss, it's an addition to our more general privacy framework.
That's great. It's really interesting how lawyers refer to gloss, and for our members who are non-lawyers, that's quite an interesting term to get your head around. Thanks for that.
It's also quite interesting too that I think most doctors would think about the Health Information Privacy Code as those are the rules, that is the law, and we wouldn't actually be thinking about, oh, hang on, there's another thing that we need to go to get some fine detail maybe about stuff. So that's an interesting concept, I think, for us to think about.
It's a really good point, and I think it's actually an important point to make there, which is you should start with the code. While I've described it sort of Privacy Act up, the code is definitely your starting point as a practitioner when you have questions about what you can and can't do with health information. And it's really, as you say, Tim, when you're getting into the weeds, that's when you might need to go back into the Privacy Act. But for the purpose of our discussion, Sam, as you quite rightly pointed out, the Health Information Privacy Code is the document we're particularly interested in.
Thanks for that, Joe. So in thinking about the scenario that Mark has just talked about, what are the provisions in the code that allows clinicians to make a disclosure without consent and do it safely?
Yeah, of course. So as I mentioned earlier, the code has a series of rules in it that we need to adhere to when using health information. And the rule we're concerned with here is Rule 11, which governs disclosure of information. When you can take information that you have received and pass it on to a third party. Often when we're dealing with disclosure, we're concerned with consent and authorization. That's the most straightforward basis on which we can disclose information to a third party. But in the situation that Mark describes, there's two more bases, and one in particular which is probably more appropriate. The first can be found in Rule 11.2a, and that applies where there's a health agency that believes on reasonable grounds that it's not desirable or practical to obtain authorization, so obtaining the consent in the circumstances simply isn't going to work, and that the disclosure of the information is directly related to one of the purposes in connection with which the information was obtained. So that is a sort of a broad brush basis on which information can be disclosed. You obtained it for one purpose, and actually the disclosure is consistent with that purpose or sufficiently related, directly connected to that purpose. The second basis, and probably the basis which we're more interested in here because it's more directly relevant, is again that the health agency believes on reasonable grounds that it's not desirable or practical to obtain consent or authorization, and that the disclosure of the information is necessary to prevent or lessen a serious threat to either public health, not so directly relevant here, or the life or health of the individual concerned or another individual. So circumstances we find ourselves in which obtaining authorization isn't practical, but actually a disclosure is necessary to prevent a serious threat to life.
Thanks. So, and just in general terms for our listeners, what kind of threshold are we talking about there?
In terms of the serious threat?
Yes.
So that's actually set up by the legislation as well. And actually we can go back to the Privacy Act, which we were speaking about earlier, and that defines what we mean by serious threat. So there's three considerations there. The first being the likelihood that the threat will be realised. So whatever particular threat we're concerned of, what's the probability that this will occur? Do we consider it likely? The second being the severity. If the threat were to be realised, how bad would it be? What is it that we are actually concerned about happening here? And the third, as referenced in the definition in the Privacy Act, is the time at which the threat may be realised. What's the imminence? How quickly might this thing happen? So in terms of assessing that threshold, it is a high one, but one that has a structure to it. There's three elements to it, and actually to again use that term gloss, to put a bit of gloss in it, there was a High Court case in 2021, which I imagine we might wind up talking about a bit later on, but it concerned the Ministry of Health's decision to not release certain data in relation to the vaccine rollout. People wanted to have more information available to them, particularly iwi, so that they could roll out the vaccine more effectively. And one of the things that came out of those High Court decisions was the High Court turning around and saying that actually the standard that had been applied by the Ministry of Health was probably a little bit too high. In particular, in relation to that imminence concern, they said, the standard that's being applied here is this has to happen basically immediately. We need to see this happen straight after the decision being made. And they said, well, no, while we need some kind of proximity in time, we don't necessarily need things to be happening straight away. The second point they kind of took it up on was the likelihood of the threat being realised. The standard that the Ministry of Health had applied was that it would be inevitable. It's definitely going to happen. And what the High Court said is, well, it is a high standard, but it's probably not quite that high. Decisions like that are helpful in one sense because they give us a little bit of security around the standard not being hard and fast, extremely high, but it does suggest that there's a little bit of latitude, a little bit of stretch in how rigorous these should be applied. I suppose the bottom line, Sam, is there are considerations to take into account. You should assess those, but probably not apply them at the highest level of stringency.
Okay. So that sounds like there's a lot of, it depends on the specific circumstances that you are facing as to whether or not it reaches that threshold.
Absolutely, and the important thing is that you consider those three factors, right, and you work through them. Yeah.
Joe, can I just sort of expand a wee bit on that imminence, but the timing thing that you referred to, because in the previous version of the Health Information Privacy Code, that was specifically referred to. It was a serious and imminent threat that was required to meet the threshold. And the word imminent has now been removed from the Health Information Privacy Code. And coming back to our comments earlier, most of us would just stick with the code and not realise that actually in the Privacy Act there is a question of timing that needs to be considered. But I guess most of the time, when we do have something that is actually serious in front of us, it's likely that it's going to be imminent, isn't it? And therefore, decisions have to be made quite quickly about whether to release the information to an appropriate source. But there might be times when that might not be the case. So if you have someone making a very serious threat, say, against someone's life, but it's not going to happen for 2 months, then that would change the impetus, if you like, to report at that stage or to make that decision at that stage.
Yeah, absolutely. I mean, lawyers love this kind of thing, words being taken out of statutes, because it does indicate that Parliament had a specific intention here, right? You don't take things out of statute for no reason, and certainly indicates that when it comes to making assessments on health information and health information in particular, which if it's being discussed in the context of some kind of clinical assessment, it would be, certainly that imminence assessment can take a back seat, or that factor isn't something you necessarily need to focus on in quite the same way. I do think it's interesting that in the High Court decisions we saw last year, it was still something the court was considering. It was certainly a factor that they commented on in the Ministry of Health's assessment of serious harm in that situation. Whether that was simply because it was something the Ministry of Health had focused on in their assessment, and so the court had to consider it, I'm not too sure. But you're absolutely right to point that out, and it does mean that when we're considering, well, I suppose these two factors for the purposes of the Health Information Privacy Code, that the likelihood of the threat being realised and then the severity, the repercussions should be your primary focus.
So, Mark, would you mind talking about an example that might illustrate these sorts of problems in the mental health sector?
Yeah, thanks, Sam. So I mentioned at the beginning that there's two common scenarios we have. One is around the requirement to consult under the Mental Health Act, but secondly that we commonly in psychiatry are taking steps to mitigate risk, and community mental health services and crisis services in particular are commonly assessing acutely suicidal individuals. Now, presuming the person doesn't require admission to an acute mental health unit, and these days the threshold to achieve that is quite high, and resource constraints. So presuming that they're not being admitted to a mental health unit, then involving family who will often be supporting this person has the potential to mitigate the risk. But, of course, you require the consent for that, and consent of the individual is always best and should be sought. But sometimes patients might decline to have family involved. And then the issue for the clinicians is, should we be consulting with family, involving family to mitigate this risk, even though the patient is declining that? And there was an interesting HDC case from about 2008 involving a northern DHB, as it was then, which kind of touched on this, which I could describe if you like. So there was a case involving a 23-year-old man who was living alone and broken up with his girlfriend, and he planned to end his life. But instead of doing so, he informed his employer and didn't carry through with his plan at all. An urgent assessment was arranged with his GP, and the GP initiated some medication and made a referral through to mental health services, commenting that the man was very anxious and also seemed to be a little paranoid. So the patient was assessed by a community mental health nurse who noted that his mood had been down for about 3 months and that he had difficulty dealing with distress. As well as the aborted suicide plan, he had made some superficial cuts to his wrist, in his words, as a way of coping with distress. So the mental health nurse referred him for counselling within the system. And then several days later, his employer took him back to ED for assessment after discovering that the man had made further cuts to his wrist, a further 5 superficial cuts. So the man was admitted overnight and was assessed the next day by the community mental health team again. The man expressed feeling very embarrassed by his situation and was explicit that he didn't want his family involved or notified. He said that he definitely wanted to live and guaranteed his safety. So follow-up plans were made, but according to his wishes, the family were not contacted. That was acknowledging that those were his wishes. Sadly, he ended his life several days later.
That is a sad case, isn't it? But I'm sure it's probably not uncommon in terms of mental health scenarios that you must see, Mark. So, Joe, and this is an example of perhaps the clinicians could have used the HIPC. Do you have any thoughts around that?
Yeah, absolutely. So this, exactly the scenario where something like 11.2D, the provision we discussed before concerning an assessment of serious harm could be used to make a disclosure to the family in question. The fact that the individual has withheld their consent or provided wishes to the contrary in that case actually just goes to whether it is practicable or otherwise to obtain their authorisation. So that's exactly what that provision is there for. It's necessary to prevent or lessen a serious threat to life or health, and you could use it in those circumstances to make that or a similar disclosure to the family.
Thanks, Joe.
There's a question that used to arise, and that is who you can actually disclose to. Can you comment on that at all, Joe? Because there's probably people that you can disclose to, or others that would be much less likely to be justifiable in disclosing to.
It's such a fantastic question, Tim. There's actually a relatively infamous case note. So the case notes are the decisions or thoughts of the Office of the Privacy Commissioner. They're not decisions of the Human Rights Review Tribunal or of the High Court. The Privacy Commissioner will encounter these cases, deal with them, and then express their views on it. And there's one concerning, I think from about 2003, a psychiatric nurse who had concerns about a patient who was being released and the fact that she believed that they were likely to cause harm. And the OPC had no issue with that assessment. It was her subjective belief. It was made on reasonable grounds. It was fine. But she sent letters informing the Minister of Health, the Minister for Police, several other individuals, and an opposition MP. So look, in those circumstances, it's sort of the most extreme example. But what it did do was give the Office of the Privacy Commissioner opportunity to sort of espouse on the very question you raise here, which is, well, who can you tell? And the short answer is the people who are in a position to do something about it. It all tracks back to the purpose of informing people. Why are you informing family? Who in the family or otherwise, other third parties you may be informing, who is it who's going to be in a position to actually achieve the outcome that you want achieved here? And that extends even further to not just who you're telling, but what are you telling them? What do they need to know to be able to sort of achieve the end here of it, presumably keeping these individuals safe? There's a sort of a concept that hovers over our privacy framework of data minimization. When you use data, you only spread it as far as you have to, and you only spread what you need to. So unfortunately, Tim, in a very lawyerly way, my answer is it depends. But you just need to keep in mind, who's going to be able to help.
Why did I not anticipate that response? Never mind.
So, Mark, turning back to you, what did the Health and Disability Commissioner say about the decision of the clinicians to not inform the family in the case that you've just talked about?
Yeah, so the HDC found that the DHB Mental Health Service was in breach of the Code of Patient Rights. The HDC noted that the man's risk was assessed as low by mental health services, although there wasn't a formal risk assessment. The expert opinion, so the HDC sometimes gets expert opinions, and so the expert opinion by the expert psychiatrist considered that if an accurate risk assessment had been made, it's likely that there would have been disclosure to the family and that would have been necessary. So the HDC was critical that a formal objective risk assessment wasn't conducted, so that then an informed decision could have been made about what support involving the family might have been needed. The HDC investigation concluded that the DHB Mental Health Service did not provide the man with the appropriate standard of care and failed to involve his family. And the HDC explicitly commented on the use of Rule 11.2d that we've been discussing. So the HDC said, when there have been several suicide attempts in a short period and there's no evidence of long-standing family estrangement, there should be a low threshold for notifying family of the risk of self-harm. Given that the family had no other social support apart from the employer, the DHB should have contacted his parents and advised them of his current mental health problems. If an accurate risk assessment had been made, it's likely that the disclosure would have been necessary.
That's a very interesting comment made by the Commissioner in this case. Probably the first point or the first question I'd like to ask about is the clinicians at the time when they saw the patient made a risk assessment, but the criticism from the expert opinion says that if an accurate assessment had been made, it is likely that disclosure of the family would have been necessary. So it suggests that the assessment that was made was inadequate. But if you think of the fact that the patient himself said that he was embarrassed about it, he reassured them that he was no longer suicidal, etc., etc., it makes me think that for non-psychiatrists, we should be obtaining a psychiatric opinion more readily in terms of suicide risk. What's your comment on that, Mark?
Yeah, I mean, this does turn on the quality of this risk assessment. And I think that there's a lot here that hasn't been unpacked around the patient's mental state and the history and all of the things that go into our risk assessments. And you're right, mental health clinicians are specifically trained in this. And, I acknowledge that this is more difficult for my colleagues in primary care. And I think here the commissioner is focusing on the inadequacy of that risk assessment. And, there are things that I have lots of question marks, like we don't know what his plan was. We don't know if there were factors that were protective. We don't even know anything about what's this comment that the GP made that he was paranoid. So there's a sense that if there had been a better risk assessment, then the clinicians would have been better in a position to make a decision as to whether they should have informed family or not.
It's also really interesting too, isn't it, that the commissioner said that because there was no evidence of a long-standing family estrangement, that was a reason for contacting them, in essence. Whereas the other thing that we were talking about just before is what evidence was there that the family would have actually been a suitable support to assist this man and reduce his risk? And that, I take it, wasn't detailed in the case.
Yeah, so in this case, it was the employer that was involved, and it doesn't appear that the family were immediately involved. And I guess it comes back to what you and Joe have been discussing, Tim, around who can actually realistically do something to mitigate that risk of harm. And often that is family. Family are the ones that may be more inclined to rally around than one's employer, as here.
It's interesting, as you say, Tim, the comment of the commissioner back in 2008 saying that there should be a low threshold for notifying the family. But we have been discussing this high threshold in the HIPC, or the Health Information Privacy Code. Mark, would you mind commenting around that?
Yeah, look, I mean, I think with hindsight, without a hindsight bias, he was a man that made some superficial cuts to his wrist, and he was a man that was guaranteeing his safety and had no current intent. So if we think about the factors that Joe's talked about in terms of seriousness, superficial cutting of the wrists, and the timing that harm may occur, he said he had no current intent. So one might wonder about whether that reaches the threshold. But as I've been talking about, I think if there'd been a more full risk assessment, we might be better in a position to consider whether that threshold is reached.
Thanks for that. Joe, what's your view on that in terms of the threshold that the Commissioner has talked about in comparison to perhaps what the Privacy Commissioner would say on this matter?
Yeah, it's really tricky, particularly when you're making decisions on what I can only imagine is a pretty urgent situation. You don't have a long time to necessarily synergize all these things in your head. What I would say, and just looking at it through the privacy lens in particular, is our Commissioner in the Human Rights Review Tribunal as well is less concerned with outcomes than it is with processes. So ensuring no matter what standards you are applying and the various factors you are having to consider, which might not necessarily be consistent with one another, ensuring that you've stepped through a reasoned process I think is the main thing. And in particular, not just in this area, but other areas, we've seen the Office of the Privacy Commissioner take circumstances where perhaps the end result isn't one that they're entirely happy with, but whether it is a practitioner in a medical field or another field has clearly worked their way through a reasoned process and given it some thought, that tends to be enough, and you can see why. All you can ask from people in these situations is that they've worked through a process and considered factors which are deemed relevant. But no, look, it's certainly tricky. I think maybe to go back to something I mentioned before about the High Court's comments on the Ministry of Health's decisions around vaccination data, they were walking back some of the wording. They were saying that we should not be applying as high a standard as maybe is necessary. And maybe just one final comment on that. Our Privacy Act, like much of our legislation, begins with a purpose section. And that purpose section sort of has two components to it. The first is to protect the rights that individuals have in their privacy and maintaining their privacy. But the second is ensuring that we don't inhibit the other interests and social goods which information is needed for. So while on the one hand, the Act, including the Health Information Privacy Code that sits with it, is there to protect information, to protect individuals' privacy, it's also there to ensure that we can do all the things in society that have to get done. And this is a really classic scenario where we're balancing those two things.
Mark, your case contrasts somewhat with a superficially similar case that I was involved with that was actually at the coroner's court. It was a hearing. And this was a 27-year-old man with significant depression who'd been to see his GP, had been referred to the mental health services, and they'd made some initial contact. His GP had started him on medication, and his girlfriend came into the consultations with him and appeared to be very supportive of him. Now, the major concern of the family, that is not the girlfriend but his own family, was that the doctor or doctors should have notified the family as well. And there the argument was not only around the privacy code, but also the fact that actually he did have someone who was supportive and who was there at the time and had all the information. And in that situation, the coroner made no adverse comment whatsoever about the doctors not informing the family. But what's also intriguing about both of these cases is that we have two authorities, neither of whom is the Privacy Commissioner, making comments on privacy issues, which is another fascinating aspect to this.
I wonder to what degree the coroner's thinking was around who was in the position to be able to provide assistance. And the girlfriend was there, and, she might have been perceived as the support person. And I think that's, goes back to the earlier discussion around, disclosure to someone who is able to make some difference.
Yeah, and this chap was the same as your one. He said specifically he didn't want his parents to know about it. So even though they lived in the same town and a relatively small one, he was very specific about that, his desire not for them to be informed.
It's a very interesting topic we've got today. And one of the things I've picked up is, Joe, you were talking about the Privacy Commissioner is interested in the process that doctors have gone through in order to arrive at their decision whether to make a disclosure or not. And in order to be able to demonstrate that you've done that, I think documentation is key, isn't it? That it's important that we as clinicians document our rationale for making that decision and make very clear, because you don't know if it's going to come up before the coroner or the HDC or indeed the Privacy Commissioner.
And I think, for mental health clinicians who are grappling with this situation that this HDC case focuses on, I think documenting that they turned their mind to the question, should we be making a disclosure under Rule 11.2d, is so important. And in fact, that's what the Commissioner commented in the decision, was there was no evidence that they turned their mind to that question.
And I think, we often advise our members as well that if you are uncertain about this kind of sticky decision and which way to go with it, that you discuss it with senior colleagues, that you take advice, that you call your indemnifier, or if you're in a hospital lawyer, to try and consult widely on this in order to make that decision. Thanks, everybody, for your input today. For our listeners, we are really grateful that you've joined us for this podcast. We hope that you found it very interesting and that you've learnt perhaps a few things from it. I'd like to thank Mark and Tim for joining me today, and especially you, Joe, for joining us from Watankani. It's been really great to have you with us.
Thanks for having me.
Cheers, Sam.
Thanks, Sam.
So if you like the MPS podcast, we would appreciate it if you would follow us and like us. And if you have any ideas about the podcast that you would like us to produce, we're certainly happy to have your feedback. And you can email us at advice@medicalprotection.org. Hopefully we'll catch you next time.